Wow, what a tough act to follow, SS. So my name is Jessica. I'm a nurse practitioner here in the cath lab at Mount Sinai. First off, I want to thank you all for coming here today. It's our 25th anniversary, so it's just very exciting, and I'm totally honored to be part of it. And I want to thank you, Beth, for all your hard work year after year for making this happen, and also to Dr. Kinney and Dr. Sharma for asking me to speak today. So a little bit about myself. I've been here for almost 5 years, but before that I worked at a small community hospital in New Jersey, and we did have a cath lab. We did 5 cases a day. As you can see from the video, we have 6 rooms going, 5 patients each, so our volume here is incredibly, incredibly high. A large amount of our referrals, though, are from the outside facilities for complex PCIs, where the facility itself just doesn't have the technique and devices in order to open the calcified vessels. So I just want to share with you briefly one of the latest techniques, which is Rotatripsy Shockwave. I have no relevant disclosures. So calcified vessels. Here in the cath lab, when we do our coronary angiography, we inject dye, take pictures with the fluoro, and this is what you see here. In addition to the imaging that we do to detect the amount of calcium in the blockage is how we determine how to open up the vessel. So here you can see we have a left main lesion. In the middle, we have that 90% proximal LAD calcified in-stent restenosis. And right here in the right coronary artery, there is that 95% mid-RCA. So who has calcified arteries? With our patients increasing in age, we do see a great number of calcium due to that factor alone. Also, our hypertensive patients, the hyperlipidemia patients, especially those with uncontrolled LDLs, diabetic patients, those that use insulin and uncontrolled hemoglobin A1Cs, and chronic kidney disease patients, especially hemodialysis. And as you notice, I basically mentioned every single patient that we see in the cath lab, whether they have 1 or all 5. So calcified vessels are a great obstacle for the interventional cardiologists and their strategy in opening up blockages because delivery of the stent is crucial. Some barriers to calcified arteries include impaired stent crossing, where the calcium itself inhibits the stent to cross through, and that can lead to dissection and perforation. And also it disrupts the drug polymer delivery. So since stents are drug-eluting stents, it inhibits the ability to implant the stent and deliver the medication. And also there is a reduction in the stent expansion and the final placement of the stent. So all these factors, as you can see, can lead to the interventionalist's worst enemy, an unsuccessful PCI, which can also lead to basically stent thrombosis and in-stent restenosis. So some techniques in order to break the calcium, as we say, is to balloon prior, where we push the calcium against the vessel prior to the stent delivery, but these are only used for mild to moderate calcified vessels. For more heavily calcified vessels, we use rotational atherectomy. It's exactly what it sounds like. It's a rotor-rooter to break the calcium, orbital atherectomy, and laser atherectomy. But these all have their advantages and disadvantages. And I guess we can say that the new kid on the block kind of is Shockwave intravascular lithotripsy. The concept itself isn't foreign to you because I know we have patients that have kidney stones, so they use lithotripsy to break the calcium, so the concept is the same. Shockwave IVL was actually used in peripheral intervention since 2016, but it's only within the past year has it been FDA approved for coronary arteries. The technique, it uses sonic pressure waves to crack the calcium. And I just want to show you a video for those that are visual learners.
The Shockwave intravascular lithotripsy system creates pulsatile sonic pressure waves to modify calcium in a safe manner. It consists of a compact rechargeable generator, a simple connector cable, and an intuitive catheter, which houses an array of lithotripsy emitters enclosed in an integrated balloon. Through the localized delivery of lithotripsy, the IVL system minimizes trauma, optimizes outcomes, and simplifies procedures. In a standard technique, the IVL catheter is advanced and placed at the lesion using marker bands under angiography. With the integrated balloon expanded to subnominal pressure of 4 atmospheres by a mixed saline and contrast solution, the fluid within the fully opposed balloon acts as a coupler to facilitate efficient energy transfer of the sonic pressure waves into the vessel wall to reach the calcium. The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. With emitters along the length of the balloon, a localized field effect is created. A small electrical discharge at the emitters vaporizes the fluid within the balloon to create a rapidly expanding bubble that generates the sonic pressure waves and then collapses within a few microseconds. When the waves impact the calcium at nearly 50 atmospheres, they create a series of microfractures. After the calcium has been fractured, and trauma to the surrounding soft tissue has been minimized, the vessel becomes more compliant. Once lithotripsy has been completed, the operator can proceed with the preferred treatment strategy to optimize outcomes. By making the treatment of calcified lesions more predictable, IVL is simplifying complex procedures.
So I hope that video helped you guys visualize how the device actually works. So here at Mount Sinai, as you know, we're all about research and data, especially with the types of devices that I mentioned in the previous slide. What makes this device different from the other? So they did a Tripsy AD1 trial that started in 2015, which assessed the feasibility of Shockwave IVL, meaning, is this device easy to use? It did determine it was easy to use. One of the biggest advantages of the device itself, there was real no learning curve. It's a balloon, you don't need a special wire. And also in the trial, there was less than 50% diameter stenosis after stenting. Also, no evidence of in-hospital MACE through 30 days. In the cardiology world, that means no cardiac death, MI, or target revascularization. So the Tripsy AD1 trial, yes, it was feasible to use, but is the device safe and effective? Because if the device isn't safe and effective, why would we use it on our patients? So you can see here it's a little bigger study, 120 patients, 15 hospitals, and 9 countries. And yes, IVL was seen to be safe and effective, no reported major dissections, abrupt closure, slow flow, or no flow. And again, that low in-hospital and 30-day MACE. But then they took it a step further with the Tripsy AD3 trial, and it was the largest and most rigorous Shockwave study. As you can see here, 431 patients, 47 hospitals, 4 countries, and the 30-day freedom from MACE was 92%. And actually, last month, the SKY conference in Atlanta, they presented the 1-year results from the Tripsy AD trial, and it showed that there was still favorable outcomes. However, despite the very positive reviews from these trials, it did show that IVL may be a new, simple-to-use therapeutic option for many patients with coronary artery calcification. However, atherectomy will remain the first-line therapy if there is difficulty crossing the lesion with even a contemporary low-profile balloon. So I guess a light bulb went off. And then they started to use both rotational atherectomy combined with IVL. And this is the newest technique to attack severely calcified vessels. Especially one of the limitations of the IVL balloon is its inability to initially cross calcified vessels. So what they would do is they would do the rotational atherectomy first and then the IVL next to finish off the lesion. And this technique has been coined Rotatripsy. So Rota, it allows the treatment of intimal calcium and permits to cross balloons or stents through severe lesions. And when adequate expansion of the balloon is not achieved after RA, Shockwave coronary IVL catheter balloon that is not usually able to cross critical stenosis without previous RA is a complementary tool to fracture deep calcium and facilitate stent delivery and adequate implantation. So as you can tell, there's this type of synergistic effect. Some advantages to rotatripsy is the ability to use a smaller rotabur. Increases in the rotabur size can lead to rupture and dissection of the artery. Also, the use of a 6 French access site to complete the whole PCI as opposed to increase to a 7 French or an 8 French, because the use of larger French catheters can lead to increased risk of site complications. Disadvantages, obviously, cost and money, using 2 devices as opposed to 1. But in the long run, I would say that if it is the most effective way to successfully place the stent, then this can avoid, say, extra diagnostic test or clinic visit if the stent delivery isn't optimal. And just like SS said, we do broadcast every month, and it's on ccclive.org, and we did a first Rotatripsy case in July 2021, and we did a couple yesterday as well if you want to check it out. And with all these new findings, Rotatripsy is definitely an up-and-coming technique, and I hope I gave you all enough information in order to understand the mechanism and the beneficial use that it can have for our patients. And thank you very much.